Hi, good afternoon, viewers. On behalf of Doc Lexus, I'm Kajal Mukherjee. Welcome you all to this session of case-based learning in ophthalmology. Diabetic retinopathy progresses through stages, starting with mild non-proliferative retinopathy, where small blood vessels in the retina weaken. As it advances to moderate to severe non-proliferative retinopathy, more blood vessels becomes blocked, reducing blood flow to the retina. In the proliferative stage, new fragile blood vessels grow, which can leak blood and cause retinal detachment or glaucoma. Treatment options include laser therapy, injection of anti-VEGF drugs, and in severe cases, vitrectomy surgery. Earlier detection through regular eye screening is crucial to prevent irreversible vision loss. Join us for an informative session on case-based learning presented by proficient junior resident Dr. Subhangi Kendre. Our panelists for today's sessions will be Dr. Mir Vaidya, senior resident, LTMMC Sion Hospital. For today's sessions, it's my privilege to introduce Chairperson Dr. Chaya Sinde, Professor and Head of Department Ophthalmology, Lokmanya Tilak Municipal Hospital, Sion. Without further delay, I hand it over to you, ma'am.
Should I start, sir?
Yes, with the permission of ma'am, you can start.
Yes, sir. Okay, sir. I'm starting my case. I'm Dr. Subhangi Kendre, second year resident of LTMMC and Sion. My today's topic is diabetic retinopathy and its management. So, a 55-year-old male patient came to the ophthalmology OPD with the complaint of gradual painless diminution of vision in his both eyes since 3 months. There was no history of foreign body sensation, redness, discharge, or watering or pain. It was not associated with any history of trauma. There was no history of floaters, and there was also no history of spectacle use for distant or near vision. His past ocular history is there is a history of PRP in both the eyes 2 months before at the private hospital, and there is no any other history of ocular surgery. In past history, he is a known case of type 2 diabetes mellitus since 10 years, and he is on insulin treatment for the same. There is no history of cardiovascular disease and any other systemic comorbidities. So on the ocular examination, anterior segment findings, the right eye vision was 6 by 60. Rest anterior segment findings were within normal limit, and left eye best corrected visual acuity was 6 by 18. On fundus examination in the right eye, media was clear, disc was normal, cup disc ratio was zero point 0.3, and in the macular region there is a hard exudates with the macular edema suggestive of CSME, and there were neovascularization was present elsewhere, dot blood hemorrhages were present, hard exudates and cottonwool spots were present. Also there are old laser marks were present, and the in the left eye the media was clear, disc was normal with CDR point 0.3, FR was dull, and blood vessel there was neovascularization elsewhere, dot blood hemorrhages were present, and hard exudates were present. So my diagnosis is in right eye there is a PDR with CSME, and in left eye there is a PDR with query macular edema. So as for the investigations, I had done OCT of this patient, and this is the OCT. The right eye OCT is suggestive of CSME, and left eye it's suggestive of cystoid macular edema. So the investigations were carried out where CBC was done, his fasting blood sugar, postprandial blood sugar, HbA1c were taken, lipid profile was checked, RFT was done, BUN and triple H values were checked. So for the management, this patient is planned for right eye intravitreal anti-VEGF injection under the topical anesthesia with the pan-retinal photocoagulation. After giving the anti-VEGF injection, as per the DRCR retina network criteria, the patient is asked for the follow-up for 1 month. Then we will check whether the neovascularization and macular edema is stable or it worsens. If it's stable, then we will defer the injection for 1 month. And if it's not stable, then we re-inject the anti-VEGF injection and call him for follow-up after the 1 month again. Then after deferring the injection, if in case it's better, then we will re-evaluate him whether there is a neovascularization has worsened or it's recurrent. If it's still not worsened, then we can ask him for follow-up till the 4 months. Thank you.
So that was a very nicely presented case.
Thank you, sir.
And so the management in this case you are talking about, uh, the last drcr.net protocols which you said, you were speaking for DME, or were you speaking in as a management for the PDR here?
I was worried about the management of macular edema in here, DME.
Okay. So usually what happens is we have to manage PDR and diabetic macular edema separately. And if you are speaking about drcr.net, so drcr.net is a multi-centric study which is usually followed worldwide, and it is the latest study with uh, and it has given guidelines for both diabetic macular edema as well as PDR. So a few important protocols which we can talk about are I, S, and T protocols, and these are for ranibizumab, which is used for diabetic macular edema in protocol I, and in protocol S, it is the ranibizumab being used as a treatment of PDR as a monotherapy, and it said that it was equivalent to PRP. It was the management using a ranibizumab monotherapy was as good as a pan-retinal photocoagulation. The only thing is that we need to consider practically is that pan-retinal photocoagulation for PDR is a permanent treatment, because once you make the retina anoxic from its hypoxic state, it is going to remain for a long time. And anti-VEGF, on the other hand, is a treatment which has to be given every month or in a pro rata regimen. So that is not a permanent solution. So that is what we follow here. We usually use PDR's treatment. We keep it as a pan-retinal photocoagulation.
Okay, sir.
Another question that I would like to ask you about this case was the what is the classification of diabetic macular edema which you used to guide your treatment here?
So there is OCT classification of diabetic macular edema is there, based upon which it's classified into 5 groups. In type 1, there is a focal edema with microaneurysms, and in type 2, there is a non-cystoid edema. In type 3, there is a cystoid macular edema.
Okay. So from the clinical point of view, what do you look at when you are saying that the diabetic macular edema is significant and needs to be treated? Then what is the main criteria? Whether we require an anti-VEGF injection, or whether it can be observed or treated with some kind of a laser. What is that criteria?
Sir, in cystoid macular, in clinically significant macular edema, if the edema is not involving the center of the macula, then macular grid laser can be given for such patients. And if the CSME is involving the center of the macula, but vision is not affected, then we can just observe the patient or give the micropulse lasers. And if there is a CSME with involvement of the center of the macula, and vision is also affected, that is less than 6 by 9 to 6 by 60, then in such cases intravitreal anti-VEGF injections can be given with or without lasers. And if the patient is pseudophakic, then intravitreal steroids can be given, or if multiple intravitreal injections have been given but patient is still resistant, then in that cases also intravitreal steroids can be given.
That's good. Yes, so what you basically said is that there are multiple classifications of diabetic macular edema depending on how the morphology is. It could be cystoid, it could be spongiform. But the most important thing which guides our management is whether it is center involving or not. If it is center involving, that is within the central 1,000 microns, and it is causing a decrease in vision, especially beyond 6 by 12. Now, here again, the protocols of DRCR net come into play. That is protocol S, which nicely told us that it is very important to treat edema, especially if the vision loss is more than 6 by 9, that is 6 by 12 or less.
But
So,
Samir,
we
if
will
the
treat with
repeat is not
anti-VEGF
required,
injections.
Dr. Mihi, sorry to disturb you. If the
Yeah.
PPT is not required, can we say stop sharing?
Yeah, sure, sure. You can stop sharing the PPT
Subhangi,
because
can you
that
stop
was only
sharing?
about the case, and now
Yeah, now the
most of it is
discussion
going to
will
be a
go on.
discussion.
Yeah. So stop sharing.
Okay.
Yeah. Dr. Mihi,
Yes.
carry on.
Yeah. So what I was saying is whether it is center involving or not is one thing that we have to see, and whether it has actually affected the vision is the second thing. If it is so, then we go ahead with anti-VEGF injections. There are multiple at our disposal that also we can select depending on the severity of the vision loss and the affordability of the patients, to be very practical about it. And what we have to see is whether we want to give steroids or anti-VEGFs. So that is a different topic. But say we are giving anti-VEGF injections, and then how are we going to monitor? So every month we will do an OCT of that patient, as well as we are going to do the visual acuity of that patient, the best corrected visual acuity of that patient, and see whether it is improving or not. 5% increase in the central subfoveal thickness or improvement by 10 letters is considered as something a change which is significant. Now, if it is increasing or decreasing, will be determined on whether the vision has increased or decreased, or the thickness has increased or decreased. So that is what we see, and we decide whether our treatment is working or it is not working, and whether we need to repeat an anti-VEGF or we need to stop anti-VEGF. If the vision has reached 6 by 6, 6 by 9, the edema has resolved, we will stop anti-VEGF and give only as and when required. If the vision is static, even after, or the edema is static, even after giving, say, 2 or 3 anti-VEGFs, right, there is not a significant change, then we will say that the anti-VEGF drug that we are giving is not working, and maybe we can switch to another anti-VEGF or to a completely different line of treatment like a steroid. However, if the change is significant in the direction of improvement on every follow-up, we say that the treatment is working. So this is what we need to know, and this has been given. So all the three anti-VEGFs were actually compared in the protocol T of drcr.net, which said that if the vision loss is less than 6, like the vision is less than 6 by 12, aflibercept is significantly better than ranibizumab and avastin, more in the first year and almost equivalent to ranibizumab by the end of second year. However, it is significantly better as compared to bevacizumab. So that is why we came to the conclusion that aflibercept was our drug of choice. So I'll ask you a few questions about the anti-VEGF injections that are there at our disposals. So can you just name one by one, along with the doses if you can, otherwise just simply the names and their brand names which are being used currently.
Ranibizumab injection is used, and its dose is 0.5 milligram per 0.05 ml. Then aflibercept, also 0.5 milligram per 0.05 ml, and bevacizumab is 1.25 milligram per 0.05 ml can be given. In here, our institute we prefer ranibizumab injections.
What is the dose of aflibercept again?
0.5 milligram per 0.05 ml.
I think it is 2 milligrams, right? 2 milligrams per 0.05 ml. And then they're coming up with newer doses which are increasing the concentrations, like say Eylea HD, which is coming, which is even higher, around 6 milligrams. So yeah, so what we have seen is, so they have been tried for different doses, 0. Ranibizumab especially, but the standard dosing is 0.5 per 0.05. For bevacizumab, it is 1.25 milligrams and 0.05 ml. And for aflibercept, it is 2 milligrams and 0.05 ml. And most recently launched drug, which is just coming in India and few doctors have started giving it, is Eylea HD, that is aflibercept at a higher concentration, which is 6 milligrams in 0.05 ml. So what it claims is that the duration of treatment, that is the interval between two injections, can actually be increased by increasing the molar concentration in an injection. Okay, these are the basic three. What are the, can you name a couple more? Have you heard about brolucizumab?
Yes.
Yeah. So what is its commonly traded name, brolucizumab? Was it is Paganax. Earlier it was given as Paganax. So that is also an anti-VEGF which has been tried in multiple conditions, including DME, AMD, as well as it has been used widely in PCVs which are non-responsive to aflibercept. But since we are talking about DME, we can talk about brolucizumab and DME. And there is one practical point which you need to know, that it has been known to cause more reactions, inflammatory reactions in the eye sometimes, but it is not significant, but not very significant also. Some vasculitis or vitritis, or in very, very rare and severe cases, vascular occlusions following the vasculitis which has been caused by brolucizumab. But it is definitely effective. And there is one more drug which you might have heard of is faricimab. Have you heard of faricimab? Okay, so in addition to the VEGF, anti-VEGF action, faricimab also has angiopoietin 2 inhibition, and it binds to the Ang2 receptors and lets Ang1 do its work. So Ang1 is responsible for the vascular stability, and Ang2 is something which is responsible for the inflammation. It has been traded under the name of Vabysmo. Okay. So, ma'am, you want to say something? You want to add something to the management and the history part, or the
Yeah, yeah.
patient management part?
Diabetes and retinopathy. Now, this diabetes, now there are two types: type 1 diabetes, type 2 diabetes. And type 1 diabetes will occur early in the earlier years of life. So, we do see young diabetics. And duration of diabetes is also important. Like this, it occurs before 30 years of age, and after 30 years, if they contract it 30 years, after 30 years, 90% of patients will have diabetic retinopathy. So it's quite important that the patient is aware. More awareness needs to be created. The patient should go at least yearly once. At the time of first diagnosis, the patient has to be referred to the ophthalmologist. The ophthalmologist has to see, and then that is the impact time. So we have to tell the patient that regular follow-up is required. It's not that you will just go to physician and take diabetes medicines and wait there. You have to come to the ophthalmologist, and at least yearly or as required, as advised by the ophthalmologist, the follow-up is required. Otherwise, we will miss the diabetic retinopathy. And what happens in diabetic retinopathy is it's a microangiopathy. So blood vessels of the body, small blood vessels, they are affected. In the eye, the small blood vessels, they are affected. What happens when they are affected? So blood vessels, the walls are affected. The walls become weak, and therefore whatever contents are there in the blood vessel, the fluid will extravasate. So capillaries, they will become weak. There will be outpouching of the walls of the capillaries, and from there the fluid which comes out will be exudates. It will accumulate. Sometimes it is hemorrhage, and these exudates and hemorrhages, they will be present in the various layers of the retina. Now it depends where they are present. Now if they are present in a small area which is periphery, it will not affect vision much. But if it is present on the most vision sensitive area, that is the macula, in that area when it occurs, vision will start getting affected. How the patient will know that there is some problem? The patient will complain of blurring of vision, because patient's other eye will compensate. So one eye, if one eye is affected, diabetic retinopathy will affect both eyes, but one eye may be affected earlier than the other, or uh, the extent and severity will be maybe different in two eyes. So the better eye will take up the function, and patient will never realize that there is problem in his vision. So when the macula starts getting affected and swelling occurs in the layers of macular retina, that time the patient will have problems. Now sometimes they will start seeing the objects hazily, blurring of vision, distance is not seen properly, distant objects are not seen properly, and they will go to optician shop and take the glasses, but never get the fundus examined. That is where the mistake lies. Then the patient will have problems in color vision. So the eyes, he will start saying that the cloth's colors or some whatever color object, red object is there. These colors, the patient will see that that object color is faded. It's not the proper color. That is also one thing. Patient may have difficulty in near vision, like they are seeing on mobile, so they are seeing blurring, not able to read the mobile messages, or doing computer typing, they are not able to do that properly, and their occupation may got okay, may start getting affected. Like tailor is there, he will get problems in near vision, he's not able to see the needle. Whatever, if the student is there, he is not able to write. So these symptoms should be recognized early. That is the message should go. And when the ophthalmologist is examining, they should dilate the fundus. At least yearly full dilated examination should be done to see what are the effects have occurred in the retina. Now, the bad thing, what is it? Neovascularization. Whenever there is a blood supply is affected of the retina, then the new vessels will start forming, and these new vessels, they will not only start forming on the optic disc, which is the part of the retina, it is a direct continuation of the brain, so it will carry the signals of vision to the brain. If that is getting affected, optic disc, there are new vessels forming, and on the retina new vessels forming, they are not normal, so they will be thin, they will be not in straight line, they will be curled, wavy, their walls are not thick, and the bleeding from these vessels is easy. They also will inside the fibrous tissue formation, and they will start pulling the fibrous tissue forms, and then it starts pulling the retina. Once this process starts, then the retina, that is a very thin layer which is responsible for vision, that starts getting detached from its normal position, and once it is detached, requires immediate attention of the ophthalmologist, and mostly it will require surgery. So to prevent this, now Dr. Meir, whatever he has named all the, and Dr. Shubhangi has named the drugs which we inject, injections are given in the eye, they will help us to prevent the complications. Whatever damage has occurred may not be reversed. If the bleeding has started and bleeding has occurred, patient should also realize that sometimes they will see flashes of light or floaters of light. So flashes of light means suddenly there as if lightning is occurring, he will see in his vision. And floaters, suddenly he will see in the field of vision that black spots are there, or when hemorrhage is there, red spots are there, and sudden shower of red spots, that is more dangerous. That means a fresh bleeding is occurring and the retina is getting full, so lightning like flashes he will see. So that means the detachment is occurring, and to prevent all these things, injections are given or laser therapy is given to the retina. That is called photocoagulation, and we may do in the required area, or grid photocoagulation, or pan retinal means the whole retina except the sensitive parts. There the retina is laser is applied to the retina so as to prevent the further complications. So these important points should be noted by the physicians and general practitioners, where they will notice that the patient's blood sugar is raised, and sometimes these patients also have other complications like diabetic nephropathy, even kidney is affected. Now when diabetic nephropathy occurs, that time diabetic retinopathy will worsen. And if it is in the young patient, then young patient, female patient, they are becoming pregnant. When the pregnancy is there, then there will be exacerbation of this diabetic retinopathy. This gestational diabetes, it may get cured after the delivery, or it may persist in the patient. When it is suddenly controlled, blood sugar is brought down. That time also changes are seen, and the diabetic retinopathy, more complications may be noticed. Even these patients may have associated cataract and glaucoma, raised intraocular pressure. When hemorrhage occurs in the vitreous, that time also intraocular pressure will rise. And these patients, the type 2 diabetes, they will also have associated hypertension. So the hypertension will also damage the retinal blood vessels, and the healing curing will not occur soon. Edema will be more, accurates will be more. Patients, prevention is important. In the prevention, lipid levels to keep them in control, keep the blood pressure in control, and keep the blood sugar in control. These are the messages should be given to the patient by the doctors.
So very nicely said by ma'am that prevention is very important, and not just to prevent diabetic retinopathy, but also to make any kind of a treatment effective, it is necessary that the sugars are controlled. So, for example, if we keep on giving injections, how many injections can we give? If we laser some amount of area and then wait for the neovascularization to recede, but still, if the ischemia wins the battle and the accumulation of end lysis products, sorbitol, or whatever the pathogenesis which is directly linked to the sugar is winning the battle against our laser photocoagulation, then I don't think there is any good prognosis which can be given to the patient. So systemic control is of utmost importance. And moving up, apart from that, one more investigation which has come into play these days for all the retinal vascular occlusions, and I recommend that we get it done even in all diabetics to prevent any kind of further problems like this, is serum homocysteine. It has been associated with multiple microvascular pathologies like, say, CRAO, stroke, kidney injury, retinal injury, and multiple things. Serum homocysteine has to be checked. Even in NAION, that is non-arteritic anterior ischemic optic neuropathy, serum homocysteine is most of the times found as the major culprit, along with an increased blood pressure. So that also has to be checked. So we can move on to a few more questions, which I can ask Shubhangi. It would be some basic questions which can be asked in the exams and would be very, very relevant to the PGs who are watching this. Uh, like we discussed about the classification of diabetic macular edema, what is the ETDRS classification of diabetes, like diabetic retinopathy?
The classification is mild non-proliferative diabetic retinopathy, moderate NPDR, severe NPDR, very severe NPDR, early PDR, and high risk PDR, and advanced glaucoma disease. So in mild NPDR, there is less than or equal to 1 microaneurysm is present. In moderate NPDR, hard exudates are present in 1 to 3 quadrants, and in severe NPDR, either three of the one criteria should be present. The hard exudates present in the 4 quadrants, or venous bleeding present in 2 quadrants, and if both the criteria are present, then it's a very severe NPDR. In early PDR, the neovascularization of the disc or neovascularization elsewhere is present. In high risk PDR, the neovascularization of disc is more than one third of the disc area, with vitreous hemorrhage or pre-retinal hemorrhages, or neovascularization elsewhere more than half of the disc area with vitreous hemorrhage or pre-retinal hemorrhages is present. And in advanced glaucoma disease, advanced diabetic disease, there could be tractional retinal detachment, or neovascular glaucoma could be found.
So everything was right, but apart from the classification of severe NPDR, which you said, so severe NPDR, the H in the HV and I is not hard exudates, it's hemorrhages. If there are hemorrhages more than 20 in all 4 quadrants, it is counted as a severe NPDR. If there is venous bleeding or looping in 2 quadrants, or if there is an IRMA, that is intraretinal microvascular abnormality present in 1 quadrant. So it is the most significant change which has to be looked for. Even 1 quadrant makes it significant to be classified as a severe NPDR. More than 2 features are there, it would be a very severe NPDR, 2 out of 3. So how to remember this? You can remember HVI and 421, and don't mistake the H to be hard exudates. These are hemorrhages, and the number is also counted in each quadrant, and then it has been given. So that is there. So after that, okay, so for the advanced diabetic retinopathy changes, what were they? That was vitreous hemorrhage and tractional retinal detachment. And in PDR, what is HR PDR? That is high risk PDR compared to an early PDR.
High risk PDR is neovascularization of disc more than one third of the disc area. with vitreous hemorrhage or pre-retinal hemorrhages and or neovascularization elsewhere more than half of the disc area.
Uh, Partly correct, partly wrong. What I would say is neovascularization of the disc. It is a easy way to remember this is that any NVD that is at the disc, if there is a neovascularization, it is much more significant than a small neovascularization elsewhere. So an isolated NVD of more than one third disc diameter can be counted as this thing. Uh, More than half disc diameter could be counted as a high risk PDR. If the NV is more than one third disc diameter and associated with VH, it will be counted as a high risk period. So NVE has to be associated with a vitreous hemorrhage. NVD can be independently also called a high risk period. And what is the definition of NVD? It is not only within the margin of the disc, it is within the margin of the disc plus one disc diameter away from the disc. So even if it's a slightly eccentric and above the disc, but within one disc diameter area from the edge of the disc, it is still classified as an NVD. So that is a high risk period. However, all that is fine. That is good for prognostication and everything. But if you see PDR, you are going to laser that patient or you are going to treat that patient. You are not going to wait to think whether it is a high risk PDR or a low risk PDR. In fact, sometimes I feel that PDRs which are not actually high risk are more dangerous because there is a chance of you missing them. And the general ophthalmologist who is seeing a PDR with a very minute NVE, which can bleed anytime, suddenly it can come with a bleed then later if you have missed it at that time. So a more careful examination is required in the cases which we classify as severe NPDRs and PDRs in which they are actually early PDRs. High risk PDRs are simple. They present with FVPs, NVs, big lesions. Even with a DO or just a 90D quick screening, you can find out that lesion. But all these early PDRs also should not be missed at. So, apart from that, diabetic maculopathy. Can you tell me the classification of diabetic maculopathy?
So,
What can it be like? It can what are the lesions which you can expect? So there are only two vision threatening lesions in this thing in a DR. One is diabetic maculopathy and the second one is vitreous hemorrhage. Okay. So how can diabetes affect the macula? What are the different ways in which a patient can be affected?
it can lead to macular edema.
Yes, diabetic macular edema. You can classify it as non-center involving, center involving. Okay. Edema is done. What else can be there?
It can be
Okay. Have you heard of ischemic maculopathy?
huh,
Yeah. So diabetic ischemic maculopathy will not actually have any edema. It will show present with thinning, disorganized retinal layers, ISOS loss, things like that. But most important thing that you will diagnose it on the basis of is an enlarged foveal avascular zone. Can you tell me two investigations which will show the size of the foveal avascular zone?
so OCT can be done to know the
OCT,
foveal vascular zone. So
OCT does not show.
FFA can be done.
Correct. FFA. So the normal size and the shape of the vessels at the edge has to be looked for. And one more non-invasive technique which has been replacing FFAs.
Angiography.
Correct. So it is based on the movement of the RBCs and at different times what is the movement of the RBCs is calculated and without actually injecting a dye, we can map uh, the blood circulation that too in different layers that is superficial, deep plexus, choriocapillaris if there are any abnormal vessels or not. So basically Opta can also be used for determining the size and the shape of a foveal avascular zone. So when you come across patients with the, decreased vision, but on OCT you don't see any diabetic macular edema, then then you can the disc is also normal. There is no blood, vitreous hemorrhage is not there, diabetic macular edema is not there. then sometimes we get confused and we might just refer a patient to neurology to assess for any cause. But this has to be done, that one of these has to be done, uh, OCTA or FFA, to actually look at the foveal avascular zone and quantify if there is any ischemic maculopathy. One interesting feature of ischemic maculopathy is that if there is a PDR associated, you might find some posterior NVs, not not posterior as in not near the arcade, but on the macula, very small NVs can also be present, and those are because of the ischemic maculopathy. But this is just a fun fact add-on. You don't look for posterior NVs to classify anything as a uh, ischemic maculopathy. Okay, so that is done. What is done? Edema is done. Ischemic maculopathy is done. Anything else which can cause a maculopathy in diabetes? It's not given in the books. I'm just asking you to think and tell me.
retinal membrane or CS
Exactly.
orbit.
So epiretinal membrane. Basically, we are speaking about traction. An
Posterior
epiretinal membrane. Yeah. So diabetes has an abnormal or anomalous posterior hyaloid, which is thickened, and most of the times it has abnormal adhesions and can cause traction on the macula if it starts contracting. So this tractional retinal detachment, if it progresses towards the macula, it can cause a vision threatening disease and has to be operated upon. Similarly, a taut posterior hyaloid, which is causing a vitreomacular traction, can also be a part of the spectrum. And the last one, which you said, is an epiretinal membrane, which is actually a tangential traction, can also be a cause. Epiretinal membrane can eventually pucker and with the centripetal force cause the inward movement of the inner retinal layers, causing disorganization and ectopic inner foveal layers. However, sometimes the epiretinal membrane contracts at the sides and it can cause a centrifugal force, causing a macular hole. So, all these abnormal vitreomacular tractions, adhesions, which are there because of the vitreoschissis, which is present, and the taut posterior hyaloid, which you can encounter in a diabetic patient, can also be a cause of a diabetic maculopathy. So edema is done, ischemic maculopathy is done, tractional maculopathy is done, and the last thing is tractional retinal detachment, which
CS
could be
retinal
included in the first
detachment.
spectrum, and the vitreous hemorrhage, which can cause a vision loss. So we have to look at the patient and decide how we are going to proceed. So what would you do if a patient comes to you with vitreous hemorrhage and says that I was seeing all good till last few days, and a couple of days back I could see some floaters, and now in the morning when I woke up I can't see anything. It's all black. I can just see a hand moving, probably nothing more than that. And say you see a vitreous hemorrhage on your examination, you cannot see anything in the eye behind, but other eye is having a PDR. You know
First,
that the patient has been followed up for PDR. What is your further line of management in this case?
first, I will do the B scan to see if there is any retinal detachment. If it's not there, then I will proceed with posterior vitrectomy, uh, uh, pars plana vitrectomy with anti-VEGF injection can be given.
One second. You will look at the B scan to rule out a tractional retinal detachment, and if it's not there, then you will do a vitrectomy.
It's
And
sudden,
what will you do if it's there then?
sudden onset. Na? So sudden onset, one day,
If
history is
retinal
one day, one
detachment
day
is
history.
not there, only vitreous hemorrhage is there, then we will wait for the vitreous
No,
hemorrhage to
so
be
you
seen.
were correct. You were correct when you said that you will do the B scan, because we have to rule out one component which indicates immediate surgery in such cases also, and that is a macular traction. If you see on B scan that the vitreous is attaching at the macula, like you will do an axial horizontal B scan, you will locate the disc just temporal to it, you will think that it's the macular area, and if you find a TRT, that is a tented up retinal appearance with a hyaloid attached, which means it's a TRD, you will classify it as a macular TRD. In such cases you can't wait, you have to intervene as soon as possible. Okay, say you have ruled out that there is no macular TRD but there is a TRD somewhere elsewhere in the periphery, above the arcades, beyond the arcades. Then it is called an extramacular TRD. In such cases, you are going to wait. How much will you wait? Or if there is no TRD, then great, you don't have to worry about anything. But if you see an extramacular TRD or a no TRD, then you wait. How long would you wait, and what will you look for on follow up?
We'll wait for 3 weeks.
3 weeks, okay, 3 to 4 weeks you will wait for. And when the patient comes to you will look whether it is resolving or not. You can't expect the hemorrhage to be gone altogether. You can be like, yeah, it is not gone, so I will go and operate. So what you actually have to do is you have to look if there is an available area for pan-retinal photocoagulation. After the hemorrhage has resolved, you have waited for 1 month, patient has come back to you, vision has slightly increased, and hemorrhage is resolving, and there is some area available for pan-retinal coagulation. Then you proceed with a PRP there. You don't go ahead with a vitrectomy because you are getting away without surgery. Why do you want to separate the hyaloid, increase the risk of breaks, this, that, complications, etc.? So you wait, but you make sure that there is an improvement in the form of visual acuity gain and decrease in the vitreous hemorrhage and increase in the area available for pan-retinal photocoagulation. Okay. But say other scenario, if this does not happen, patient comes back to you 1 month later with no area available for PRP and no improvement in vision, nothing else, probably a macular TRD which is going on also. Then you will go in with surgery then and there itself, and you will decide whether to spare the lens or do a ecovitrectomy depending on how it will give you, like whether there is an enough cataract or not. Unnecessarily you will not do this thing, a cataract surgery combined with a vitreoretinal surgery, especially in diabetes, because what happens is if you unnecessarily remove the cataract, the VEGF load which is there behind gains easy access to the anterior chamber, and it can increase the frequency of NVI and NVA as complications and the neovascular glaucoma setting in a case of PDR. So you don't do it unnecessarily, but if visualization is being hampered, then you remove the cataract along with it. So TRD, you have to manage. If it's there at the macula, you have to go in. Extra macular TRD can be observed with PRP, it can regress. Okay, one more important aspect. Would you give preoperative anti-VEGF, and what is its role in a patient with VH and say FPPs, TRDs?
The preoperative anti-VEGF can be given to decrease the formation of new vessels, so that VEGF secretion will be decreased, and retinal hypoxia will be decreased. So retinal oxygen in the center is increased. So when we do the actual surgery, the bleeding there is a lower risk of bleeding occurring.
Yes, that is the most important point, to decrease the intra-op bleeding. The risk of intra-op bleeding has to be reduced, and that is why we are giving preoperative anti-VEGF, which has to be given around 3 to 5 days before surgery. If you give it in a tractional retinal detachment, however, and then you can't do the surgery, then what can happen?
Can you ask once again?
If you have a patient of tractional retinal detachment, you have given anti-VEGF, you have planned a surgery after 3 days, and suddenly the patient is not fit for surgery with crazy sugars, say 500, 400, then what is the risk which the patient is facing at that moment? So have you
Traction.
heard of crunch phenomenon? So I'll tell you, crunch phenomenon is something in which, in a case of tractional retinal detachment with fibrovascular polyps, you have given anti-VEGF, then the fibrovascular membrane starts contracting, and this contraction causes traction and leads to a tractional retinal detachment. This is called crunch phenomenon. So that is why 3 to 5 days duration is important between an anti-VEGF and the surgery, and hence it is very important in, from the practical point of view, that fitness and clearance for surgery has to be obtained before giving the patient the pre-operative anti-VEGF injection. For diabetic macular edema or just VH with no TID, nothing like that, then that is not required. Fitness for injection would be required. But if you are planning a pre-op injection and followed by a surgery, then you have to have the fitness for surgery and not just the injection. So that is an important point here.
Thank you, sir.
So I think more or less we are done and we have covered the management of diabetic retinopathy. And it is a vast topic, not really we won't be able to cover it completely and do justice in a 1 hour lecture, but still we have managed to cover a lot. And it was a great presentation and case was explained nicely by you. And Chaya ma'am also gave us the very important practical points of how we deal with the patients, how a patient can face a difficulty when when suffering from a diabetic retinopathy or a macular edema, how it affects the activities of daily living. So, yes, thank you so much. And over to you, ma'am.
Yeah, thank you, Mihir and Shubhangi. It was a nice presentation. In a short time, she prepared the case, and Mihir has given thorough understanding of different classifications were discussed very nicely in depth. It was exam preparation also for Dr. Shubhangi. So it was a really interactive session and very nice session. I thank Mr. Kajal Mukherjee and Dr. Lexus for this wonderful platform for our students. It is a very good learning experience. Thank you very much.
Thanks, ma'am. Thanks a lot. Thanks, Dr. Subhangi, for your wonderful presentation. And thanks, Chaya ma'am, for making this type of session possible on Docplexus platform. I really salutes your thought process towards percolating down the medical knowledge to the younger generation. And my sincere thanks to Dr. Mir Vidya for his expert inputs. In fact, it was just like as a thorough, as ma'am says, thorough details of these cases. I'm sure that this will help the PGs and young ophthalmologists across India to utilize their learning to handle diabetic retinopathy. Those who have missed this knowledge filled event can see it recorded on DocPlexus platform on the past event tab. So please look forward to DocPlexus platform for more interesting session like this. With this, I request to Dr. Shah ma'am to say some final words and close this session.
Yeah. So for the doctors and ophthalmologists, we have to diagnose early and treat early. More awareness needs to be created. Patients should visit the doctors early, keep their blood sugar, blood pressure, and levels in control. Awareness should be there in society. Support is also needed. Accessibility of the healthcare and availability of the drugs, which whatever medicines are needed, even dietary advice, the correct dietary advice as per the particular patient is also important. All these things together will lead to a healthy patient.
Thank you, ma'am.